Okay. I'll wait just a couple of seconds, then we can start. Okay. Okay. Good evening, everybody. Welcome to this very exciting session of Journal Club. Today, we're going to discuss about the PROTECT-TAVI, an important study which was recently presented at TCT Congress and published in the New England Journal of Medicine, addressing the issue of cyber protection during TAVR. My name is Alessandro Beneduce. I'm an interventional cardiologist, and our presenter today is Dr. Ozan Demir from London, UK. And as a senior expert, it is my absolute pleasure to introduce you someone who really needs no introduction, Professor Lars Sondergaard from Copenhagen, Denmark. So we really have an all-star team today, and I'm delighted to be with you today. So for all of you who are joining us today, please feel free to ask any question by typing in the chat below. We will address them later on during the discussion. And please remember to follow the Journal Club on the social media and to subscribe to our YouTube channel. And finally, if you ever want to take the stage of the Journal Club, please feel free. We are an open door for fellows, and you are all invited to join us. Ozan, if I could please invite you to share your screen, I'll hand over to you shortly. In the meantime, we're going to briefly analyze the results of today's poll created by our social media team. So the question was, when do you protect the brain during TAVI? The results are quite interesting. The 50% of responders answered in selected cases, while the rest equally divided into all cases or never. And less than 10% of people, and I put myself in this category, answered waiting for more data. So Ozan, we are really looking forward to your presentation, and I'm sure that the discussion with Professor Sondergaard would be enlightening.
Brilliant. Thank you very much for the introductions, Alessandro. So as mentioned, my name is Ozan Demir. I'm an interventional cardiology fellow in London, based at Hammersmith at the moment. And I think it's a real pleasure that we're able to have Professor Lars Sondergaard with us, who's an expert in this field and a co-author on this paper that's really sort of been highly sort of cited and discussed on social media and beyond in cath labs across the world. So I'm going to start with a brief background, which is to say that we know that aortic valve replacement, whether surgical or transcatheter, is associated with stroke risk. And that risk is pretty similar using both forms of intervention. With regards to transcatheter aortic valve replacement, there are two main sort of peri-procedural components to it, one of which could be due to atherosclerosis, and guide wire enlarged wall catheters dislodging these, sending debris north into the cerebral vessels and causing strokes. Second sort of secondary points is where the device position and implantation leads to thrombus formation in the catheter or the delivery system, which likewise causes cerebrovascular accidents. And these are the two main mechanisms that this study tried to address with regards to peri-procedural influx. The third is subacute embolization, and this is more to do with patient factors, for example, coagulative states, atrial fibrillation, which we won't go into, but it's important to note that subacute embolizations do occur. And I'm sure many of you will have seen this nearly 10 years ago. Nicholas van Meegen and colleagues presented a paper which looked at histopathology as well, with debris that were collected in embolic protection devices. And as you can see, in these quite large debris were picked up during procedures, and the histopathology that was performed on these subsequently showed a wide array of debris that were collected, including calcium fragments, valve fragments, plastic fibers, and valve tissue itself that was picked up by the embolic protection devices. So illustrating that there's a wide spectrum of debris that are that can cause cerebrovascular events in these patients. And we know from previous studies that the majority of strokes happen during the peri-procedural period. And we can see here that strokes after TAVI are within this period, and even in transfemoral, which is the modality or the access that this study looked at, was seeing events. And we know that patients who have cerebrovascular events following TAVI have poorer outcome than those that don't. And this was also sort of illustrated with the TVT registry, showing that 30-day and discharge at home sort of values. So 30-day mortality significantly worse in patients who had strokes, and patients who were discharged home, there was significantly fewer of those who had cerebrovascular events as well. And with regards to the device that was investigated in the study, this was a Sentinel device. This is a 6 French delivery with 2 filters, one being proximal in the brachiocephalic tract here, and the secondary in the carotid artery. And we can discuss different devices and how that may impact practice and results in other studies later on as well. But the purpose of this study was to look at the Sentinel device, which is very widely used, and probably the most widely used device internationally. So the PROTECT-TAVI study was the objective to which was to study the whether clinical stroke in transfemoral TAVR was reduced by using cerebral protection devices. This was a prospective, multi-center randomized trial, importantly including centers from North America, Europe, and Australia, 51 of which participated. Very large study with 3,000 patients. It was a one-to-one recruitment with 1,500 in each arm. And importantly, patients had neurological examination by a neurology team pre-procedure and post-procedure, and that post-procedure examination dictated whether or not they had strokes, and they had subsequent investigations if required at the discretion of the neurologist on site. The primary endpoint was all strokes at 72 hours or discharge if that happened before the 72 hours. And there's a point here about adaptive study design, which I'll discuss very briefly. So the statistical method that was used, that there was expected stroke rate of 4% in the control arm and a 2% stroke rate in the Sentinel arm, the intervention arm. There was assumed a 50% reduction in stroke using the Sentinel device, and this was powered for greater than 90%. As with recent studies, there was a planned power calculation of 3,000, but an interim analysis was performed looking at 70% of the enrollment to adjust, if necessary, for event size. And this was reviewed and felt that 3,000 was the correct size, and therefore the study completed at 3,000 patients. The primary endpoints, just to emphasize this once more, was stroke through to 72 hours after the procedure or at the point of hospital discharge, whichever came first. It was adjudicated by independent clinical events committee, each event, that was based on the neuro-arc definition, which is outlined here below. But essentially it's ischemic stroke, symptomatic intracranial bleed, stroke that's not specified by these two, or covert cerebrovascular symptoms. And this is additional adjudication, which looks at, in addition to this, whether it's a disabling stroke, the mortality, whether it's transient, and other comorbidities associated with it. The flow chart, just to emphasize that the vast majority of patients, if we look at this as a control arm and the intervention arm with this protection device, the vast majority of patients who were randomized to cerebral protection device had it performed. Only 5.5% where it was not possible, which is an excellent sort of patient selection and intention to treat arm. And just coming to the point, the primary analysis was an intention to treat population. So despite it not being performed in 5.5, those patients were within this intervention arm. So the next slide, I believe, is the demographics. So we can see that these are all, as it's a randomized controlled trial, it's very well matched. Importantly, there's a good spread of patients with high, intermediate, and low risk, nearly a third in each of those categories. Calcification was severe in 50% of patients, and the CHA2DS2-VASc score was 4.2 and identical in both groups. The vast majority of patients, the procedure was done with local anesthetic or sedation. Tricuspid was the vast majority, bicuspid accounted for around 8.7%, and balloon expandable valves were the valves of choice at each center in the vast majority of patients, with pre-dilatation occurring in up to 41% and post-dilatation in 26% of patients. And this is the primary endpoint, the results of the study. So if we look at the all strokes here, there was a 2.9% stroke rate at 72 hours in the control arm and a 2.3% in the intervention, the cerebrovascular protection device. and this was not statistically significant, and therefore the study was deemed to not show superiority for cerebrovascular protection devices. However, importantly, we should just note that this is less than what was predicted in the control arm. We can discuss that later. Importantly, what was noted was that non-disabling strokes, there was no difference between the two arms. However, in disabling stroke, there was a significant reduction in disabling strokes in patients who had the cerebroembolic protection device implanted. And when we look at this in a bit more detail, if we just focus on the disabling stroke, as there's no difference between the others, we can see that it's the ischemic stroke subtype that is significantly reduced in patients who had intervention performed. And when we look at clinical outcomes, that's within the study, these were very comparable between the two populations, with all-cause mortality 0.5% or less, cardiovascular mortality very similar, and composite endpoint of all-cause mortality of stroke very comparable between the two groups. So very well-matched population with regards to all-cause mortality and other endpoints. With regards to subgroup analyses, and these are hypothesis-driven analyses, we can see that if we look at disabling stroke, where there was a difference, one could argue there is no clear statistical benefit within these subgroups using this form of analysis. So I think it's very clear that the results of what they've sort of shown us, and we'll discuss that briefly. With regards to the trial limitations, I mean, this is a practical trial. To be able to deliver a 3,000 patient trial, it has to be practical and deliverable, which is very understandable. Anyone who's involved in trial management and design. As a consequence, was restricted to a small number of endpoints with short-term follow-up. Neurological professionals who performed patient assessments were not blinded to patients' course and hospital records, and the study was not powered to detect for treatment difference in disabling stroke. And we can discuss that as well a bit further on today. And the main conclusions from the study that we should all take is that the use of the Sentinel device was feasible in the vast majority of patients, 94.4%, and it was safe without major complications. It did not result in an overall reduction in periprocedural stroke within 72 hours. There was fewer disabling strokes that was picked up within if you had cerebrovascular protection devices. However, it's important to note that the study was not powered for this, as was one of the limitations outlined. And there was no specific subgroups that were identified which strongly favored cerebroembolic protection devices for use. So those are the slides I have. I think Professor Sondergaard wanted to discuss a few points that he wanted to highlight from the study, and then we can go on to discussions.
Yeah, I think that was an excellent overview of the study. So before we start the discussion, I can just give you my perspective of what we actually saw in this trial here. So I hope you can see my screen here.
Yeah, we can see that.
Yeah. So first of all, you can ask yourself what kind of patient was actually included in this study. So you saw that in the study design, there was an expectation that patient in the control arm had a stroke rate of 4%. And what it actually showed in the study was only 2.9%. So you can ask yourself, was a patient selection bias? Did some site choose to treat patient at a high risk for stroke outside the trial using the Sentinel device? It could be patient with valve-in-valve procedure, bicuspid aortic valve, severely calcified valve. But again, if you look into what patient actually went into it, you can see that first of all, I would say it was intermediate to high risk patient. STS score was 3.4%. Bicuspid aortic valve in the control group accounted for 8.1% of the patient, and valve-in-valve procedure 2.5% of the patient. So I'm not sure there was so much patient selection bias that site choose to treat patient considered at high risk of stroke outside the study using the cerebroembolic protection device. Second question you can ask yourself is this device efficient? Predicted stroke rate in the test arm, in the test group, was 2%, and it actually came out at 2.3%, a little bit higher. And of course, you could ask yourself, is this device fully efficient? You know, it consists of two filters, one sitting in the brachiocephalic artery and one sitting in the left common carotid artery. So the left vertebral artery is not protected, and this accounts for about 10 to 15% of the flow to the brain. So saying that we couldn't meet the primary endpoint in this study is not the same as all cerebral embolic protection devices will not do it. You know, there's also other devices such as the TriGuard, which is a deflection device, which is sending the debris anywhere but the brain, but covering all neck vessels. So that could be more efficient than the sensor device. Second thing you can say that maybe even though it included 3,000 patients, it could potentially be underpowered, this study. We saw there was a numerical reduction in all strokes from 2.9 to 2.3%, but again, did not reach statistical significant level. P-value was 0.30. And that is, of course, a concern that we need even more patients to show there's a benefit. We know that as a second trial ongoing for the time being, the British Heart Foundation PROTECT-TAVI, which is going to include even more patients, 7,730 patients, so 2.5% larger than a protected TAVR trial. It's a very similar study design, randomizing patient one-to-one to TAVI using cerebral embolic protection with a Sentinel or TAVI without cerebral embolic protection device. And the primary endpoint is also the same, all stroke at 72 hours or at discharge, whichever occur first. The only difference between the two trials is that in the protected TAVI trial, all patients was assessed by a stroke neurologist before and after the TAVI procedure. That's not going to be the case in the British Heart Foundation PROTECT-TAVI trial. But again, there's a pre-specified meta-analysis in already planned for these. Combining these two is going to give you almost 11,000 patients. And one thing which is also very important to know about the British Heart Foundation study is that cerebral embolic protection in the UK is not reimbursed. It's reimbursed in Europe and in America, and that was, of course, giving the physician a chance to treat patients with cerebral embolic protection outside the trial. Again, as I said before, if they had patient considered a particularly high risk of stroke, that's not going to be the case in the British Heart Foundation because the device is not reimbursed. And as I said before, it's going to give them opportunity for a meta-analysis, which is already planned, combining the protected TAVI and the British Heart Foundation PROTECT-TAVI. It's almost 11,000 patients, and that should give power enough to show that there's an effective reduction in all strokes using sensor device, if it's actually the case. Then you can say that we missed the primary endpoint. There was no statistical significant difference in all stroke, but if you look at a secondary endpoint, disabling stroke, there was actually a significant reduction from 1.3 to 0.5%. First of all, you can say that it's difficult to look at the second endpoint if you miss the primary endpoint. It's at most going to be hypothesis generating this secondary endpoint. But again, if you ask the patient or the family or the treating physician, I think those are more concerned about disabling stroke than non-disabling stroke. So here again, it was an 0.8% reduction. And if you do the calculation, you can see number needed to treat is 125 patients. So you need to use this device 125 times to prevent one disabling stroke. And that may seem a high number. But again, it's also partly due to that disabling stroke luckily is quite rare in modern TAVI procedure. So even if you had a perfect device, which is going to leave none of the patient with a disabling stroke, so you come down from 1.3% to 0% in the test arm, the ideal number needed to treat will be 77 patients. So that's what you're up against when you have complications, which is quite rare, that the number needed to treat is quite high. So 125 patients is the number need to treat in this study. I'm in a study in a site where we do about 500 cases a year, TAVI cases, And using this device, you can see here that's going to reduce the number of patients with disabling stroke by 4. So 4 patients will prevent a disabling stroke, and I think that certainly something you need to take into considerations. And finally, there's also a limitation in this trial. This trial was a very pragmatic trial, as you heard. It was only looking at what happened in hospital. We know when you use this device and you look at both inside the filter afterwards and you do a MRI scan of the brain, there will be a lot of what we call these so-called silent brain lesions. And this lesion may not be benign. If you ask a stroke neurologist, he will say this is going to put the patient at risk for cognitive impairment and early dementia. And I think that's particularly important if we expect that TAVI is going to expand to patients at a younger age with longer life expectancy, that these patients may be at risk for early dementia. And this is, of course, not captured in the protected TAVR or the PROTECT-TAVI. So to study this, we need another study to actually see what is the long-term consequence of these so-called silent brain lesions. So I think I will stop here and be more than happy to discuss both you saw the study and my personally perspective of it.
So thank you very much. If any one of you has any question, please feel free to ask.
So hi everybody, and thank you for the presentation and for your comment, Professor. So I'm Marco Toselli from Italy. I would like to ask you if having this data, which patient you would protect, and if there are some subgroups of patients that deserve embolic protection. And about the low-risk patient, also, I would like to know your opinion. These are maybe the patient anatomically have a less risk, but of course we have to look and give them the best treatment option. So, what your takes from this point of view? Thank you.
Yeah. First of all, I would say today we treat all patients who is eligible for the device. If you can see on the CT scan, there's a good chance to put the device in, we'll do it. So it'll mean that around 90% of the patient will actually have it. We don't select patients. And you saw the event rate was so small in PROTECT-TAVI, it's impossible to identify a subgroup which may be a particular risk. I think if you ask physician, they will say patient with bicuspid aortic valve, patient with severely calcified aortic valve, valve-in-valve procedure, patient had a stroke in the past, are particularly at risk. But again, we have no data on that. So I think it can happen in all patients, and I think we should use it in all patients. We have seen today the penetration of Sentinel is not particularly high. It's about 7% of all patients undergoing TAVI in Europe, where it's going to be used. If you go to the US, it's 17% of the patients. So my feeling is that this is going to not really to change the practice. I don't see the number is going particularly down or particularly up. I think most sites will wait and see what's going to happen in the PROTECT-TAVI trial, and particularly in the meta-analysis. I can just say the PROTECT-TAVI trial is close to 3,000 patients enrolled, so I still have a while before it's completed. But I think it's going to be a kind of a status quo for the next 2 years before we have those data.
Great. Anyone else? Any other questions?
I have a question. Hi. Can you see me?
Yes.
Yeah, we can hear you.
Okay. Hi. So I have a lot of questions in my mind. My first question is very short about the role of atrial fibrillation in this patient. A third of patients in the PROTECT-TAVR had atrial fibrillation, but there was not a pre-specified sub-analysis about this. And also, if I'm thinking of a real practice TAVI, sometimes we skip anticoagulation in the first day of the TAVI procedure, especially if they have bleeding from the access, and this is everyday practice. So I would like to hear your comment about it. And second, from your experience, the inclusion criteria for the study was the absence of anatomical contraindication for replacement of a Sentinel device. So in your opinion, what is the neurological outcome in patients that cannot receive the Sentinel device when they perform TAVI? I mean, is it possible that this population consists of patients that have anatomical complexities, a lot of calcifications, or maybe those in dialysis having fistulas on the radial artery, so they cannot receive the transradial device? So do you think that this is, of course, not a huge population, because I think the screen failure is less than 10% of all the CT scan for the sentinel placement. But this is also, I think, another group of patients that are potentially at a higher risk for stroke, in which, and this is for the future perspectives, do you think we should work also on more devices, newer devices, something like an updated versions of the TRIGARD, I don't know, something different that maybe will help also in those complexities?
Yeah, I mean, that's two very good questions. First, we should start with your last one. You know that Boston have also been looking to the sentinel device to cover all neck vessels. It's not feasible today. You can use the TRIGARD. The TRIGARD is a deflection device. It's not going to capture the device. It's going to send it anywhere but the brain. The good thing about the sentinel device is that when it's in place, it's quite easy to do your TAVI procedure. It's not going to interfere with your delivery system. The TRIGARD is a little bit more complex because it's sitting on the roof of the arch, so your system may interfere with it and it may not be 100% efficient. And that was what I also was trying to tell you here, that maybe these devices are not perfect as they are designed now, but it may change down the line. Your first question was about AFib, or you can also say in general, just remember these devices, the sentinel device will often be in the patient for about 45 minutes before it's out again. The primary endpoint was captured at 72 hours or at a discharge, whichever occurred first. And of course, there's a risk that the patient will have a stroke after the sentinel is going up and before the patient is actually discharged. And one group, as you rightly mentioned, is patients with AFib, because we tend to pause their anticoagulation. Of course, there will be a risk for these patients, but also patients in sinus rhythm that will have a stroke after they're leaving the cath lab. Some of you have heard that, you probably know the popular TAVI trial, which is combining different kind of antithrombotic therapy. There's another study going on called popular PAUSE. So this is patients who have an indication for oral anticoagulation. So you randomize patients to continue it during the procedure or to pause it, as most patient site will do today. It seems that it's, at least from our experience, it's quite safe to just let the patient continue on oral anticoagulation during the procedure, and afterwards it's not going to be related with major bleeding. And that may also give a further reduction in stroke. I hope that answers your questions.
Yeah, sure, absolutely. But I was curious why there was not a pre-specified sub-analysis in the group in patients with AFib. I didn't see that in the paper.
But there was,
published.
I mean, it looked at a lot of subgroups, but again, event rate was pretty small in this group, so it's difficult for the primary endpoint to show it in subgroup analysis. The only thing which actually came out that the sentinel device seems to work better in the US than in Europe or outside US.
Yeah.
I think that's random. I mean, it's by chance. It was just barely significant, but.
Okay, thank you for your answers.
Okay.
Just on the sort of national sort of question, I guess one of the things that you mentioned, Professor, was that in the UK, obviously, it's only used for research purposes and it's not routine practice as it is in other European countries and certainly the US. So from your experience, what's the learning curve for the Sentinel device? And do you think that that will have an impact for the HF PROTECT-TAVI trial?
Yeah, it's actually quite easy. If you have used it a few times, it's easy to put in. It's also very safe. You saw there was only one access side complication, so it's a really safe device. What people are mostly struggling with is patients who have a bovine arch. So to get it up there, if you have a little bit of experience, you can do it. If you don't have a lot of experience, you can just start going in with a Judkin Wright or EMA catheter and just bring a long coronary wire up and then afterwards follow with your device. So I think even in complex anatomy, it's quite easy to use it. And you also saw in PROTECT-TAVI, it was about 95% of the patient who was planned for the device who actually have percent of the patient who was deemed that it was anatomically suitable. It was possible to implant the device.
Thank you.
Okay, that's great. I think we covered pretty much all the questions. Thank you very much for both of you for this exciting session, and really happy to have hosted this session. And this will be soon available on YouTube for review. And then see you the next time for Journal Club. Thank you very much.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.